Fahrialsyam, SPPD KGH MMB, and all of the Dean's Office, representative of Director of Human Resource and Education, Cipto Mangunkusumo General Hospital, representative of Director of Indonesia Medical Education and Research Institute FMUI, Profesor Dr. Badriul Hegar Syarif SPAK PhD, Head of Board of Professor, Head of Senate Academic Faculty, Heads of Department, Professor Cesar Alfonso MD, and to all ladies and gentlemen. Good morning. A very warm welcome to our faculty for the conferment ceremony of Adjunct Professor, Professor Cesar Alfonso MD, Tuesday, 16th of July 2019. My name is Leonita Ariesti Putri, and I will be the master of ceremony of today's event. Before we go on to the main ceremony, please allow me to recite the rundown. The ceremonial of Adjunct Professor will be started by the speech from Dean Faculty of Medicine Universitas Indonesia, Profesor Dr. Ari Fahrialsyam, SPPD KGH MMB, followed by conferment ceremony of Adjunct Professor to Professor Cesar Alfonso MD, and last but not least, we are going to hear the inaugural speech from Professor Alfonso. Distinguished guests, ladies and gentlemen, now we invite our Dean Faculty of Medicine Universitas Indonesia, Profesor Dr. Ari Fahrialsyam, SPPD KGH MMB, to give the speech. Professor Ari, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Morning. So first of all, our distinguished guest, Professor Cesar Alfonso, and we are happy that we have our teacher here, Professor Dr. Sasanto Wisono. Thank you for coming. And also we have Professor Irawati, seniors from Psychiatry Department and also Head of Department, Dr. Sister. And I also here we have Director and also Vice Director of IMERI. And we have some professor from and also staff from some department in Faculty of Medicine in Indonesia, ladies and gentlemen. So yes, I would like to give my highest gratitude for Professor Alfonso, all the way from Columbia University Medical Center, New York, for his kindness and also his contributions for our psychiatry department. Our collaboration extends to lecturers, research, and publications. And I got information from my colleague from Psychiatry Department that Professor Alfonso has taught psychiatry directly to our students from Faculty of Medicine, University of Indonesia. And not only directly, but also by teleconference. Thank you very much. And yes, please, if you want to give applause for him, don't worry. And we know that Professor Alfonso has also collaborated with many staff from Psychiatry Department to produce many scientific publications in international journals, and I think also for his generosity for including our Faculty of Medicine Information staff from Psychiatry in World Psychiatry Association, Academic Consultation and Licensed Psychiatry, and also invite our staff to the American Academy of Psychodynamic Psychiatry and Psychoanalysis. Thank you for your collaborations. Actually, I'm a fellow of I'm also fellow of American College of Physicians, and I also fellow of American College of Gastroenterology. So I am part of American as well. Yes, today inaugurations for Professor Alfonso is one of our effort to achieve our ambitions. It's one of the most prestigious university, not only in Indonesia, but also in Asia Pacific region. I am here as a representative of University of Indonesia, will give Professor Cesar Alfonso as honor as Adjunct Professor. This title is given to you for his hard work and dedication to improve the quality of clinical practice, knowledge, and also contributions in Psychiatry Department of Faculty of Medicine, University of Indonesia. We thank you for the hard work, time, and miles you have spent for us. And it is honor for UI, especially for Faculty of Medicine, to have a good collaborations with you, and I hope it will be continue in the future. So I'd like to invite Professor Alfonso to please come forward and receive the award and as an adjunct professor of University of Indonesia.
Professor Ari and Professor Alfonso, please remain at your place. We would like to invite Dr. Christiana Sister Kurnia Santi, SPKJK, as Head of Department of Psychiatry, to join the group. Deliver his inaugural speech entitled Psychotherapy in Consultation Liaison Psychiatry, Reducing Morbidity, Improving Adherence, and Prolonging Survival. Professor Alfonso, the time is yours.
Can everyone hear me? Okay. What about at this distance from the microphone? Thank you. It's really I must say this feels like the highlight of my professional career. So I will try not to get emotional. Right now I have goosebumps, piloerection in medicine. So I am very excited to be here and very thrilled and very grateful. So I would like to thank all the very important people who are here, but also the faculty that work so hard to train, such bright psychiatrists and medical students that are really the future of medicine and psychiatry in this country. So I would like to really thank everyone for being here, from the top down and from the bottom up as well. So this is the title of my presentation, Psychotherapy in CLP, Reducing. Maybe I can hold the microphone. Yeah. Okay, move this away. Much better. So, psychotherapy in CLP, reducing morbidity, improving adherence, and prolonging survival. And it's quite a lot to cover. But if I'm running out of time, send me a signal, and I will skip some slides. You'll have my email address at the end of the presentation, so I can send you the complete set of slides if we do not have enough time to complete. And these are some of my credentials, the different things that I'm currently involved with. And this is a photograph of my, how all of this, how my connection with you started. In 2014, we held a workshop. You probably, many of you recognize yourselves in this photograph. I'm actually wearing the same batik. And I did that in purpose because this is a very important, this was a very important symbolic event for me. And, in addition to all the now very famous Indonesian psychiatrist. There's a person standing in the middle in the back who was infiltrating the Indonesian group, and that's Dr. Hasli Zakaria from Malaysia. And he's the one who eventually invited me to become a visiting professor at UKM, another place that's dear to my heart. But my contract there is ending, so my efforts now will be at the University of Indonesia. So don't think that I am going to split my alliance. My primary alliance really is to Columbia University, is my parent academic institution, but I'm really trying to dedicate my academic effort to one institution at a time, one additional institution at a time. So Universitas Indonesia comes next. This was another event with some very important people in the photograph, and it didn't stop there. We've really been going around the world and meeting all wonderful folks. You can see as recently as a couple of months ago in San Francisco, Mexico City 2018, Florence 2017, New York City. That picture in New York City was taken on a bench in Central Park. 2018, Florence, Malang, and it keeps going on. London 2018, Berlin 2017, Marrakesh 2018, Taipei 2015. As of last week, we held a very important conference jointly with the MCPM in Malaysia. Important because it was the first international meeting of the World Psychiatric Association Psychotherapy Section. It's the first time that the WPA recognizes the need for to protect psychotherapy in psychiatry. And I think I was able to capture all the folks from Indonesia who were presenters, not only in attendance, but actively participating. So you had the largest group of people presenting at this conference. So, you have to congratulate yourselves for this. And this is a list of publications in the last 5 years, including at the very top, a publication that's in process. I mean, just this afternoon, I will have a meeting that this paper was submitted to Asia Pacific Psychiatry. You may know the editor-in-chief of Asia Pacific Psychiatry is Dr. Alan Tasman, and he recognized the importance of this paper. He told me that, it needed to be fixed, it needs to be changed. He actually disagreed with the comments of the reviewers, and he said, we have to make sure that this is an important message. We need to know how medical students feel about psychiatry. Very little has been written about this in this region of the world. So he asked me to tag along as a senior author, not to fix the paper, but to focus it. And we're having a planning meeting to try to get that done within this year. And another publication that's in process, that it's actually the first draft. First draft is due December 1st. A chapter in an important book published by Springer, and some other publications in high impact factor peer-reviewed journals, British Journal of Psychiatry International, Psychiatric Clinics of North America, and in a chapter in a book, Advances in Psychiatry. Okay, so today we will review the essential principles of psychotherapy in the care of persons with complex medical illnesses. Try to understand the relationship between stress and illness and the concept of allostatic overload, and this will be defined, and how group psychotherapy may impact not only reduction of psychological distress, but prolonged survival. Review studies suggesting that environmental stressors cause DNA methylation and how psychotherapy may reverse this process through demethylation. In other words, you may want to begin to consider that psychotherapy is actually a biological treatment and not something that is unscientific. It can work, it's been measured to work at the DNA level. Understand how countertransference awareness may facilitate liaison psychiatry interventions, and review how attachment theory informs our understanding of non-adherence to medical treatment, a problem that we all struggle with in all specialties of medicine. Don't know if we'll be able to cover all, but we'll try our best. All psychotherapies, regardless of your regardless of how you identify yourself as a CBT person, DBT person, IPT, psychodynamic psychotherapy, all psychotherapies have the basic substrate. And it is in the commonalities of psychotherapies that are actually, and these commonalities are actually the transformative elements of psychotherapy, much more so than the very other specific interventions that sort of build upon these. So, it is important that you feel comfortable doing supportive psychotherapy, and I'm telling you that that's probably 70% of what will benefit your patient. If you do more than that, it's going to be wonderful. If you can get to 80, 90%, you do that by adding CBT or psychodynamic interventions to supportive psychotherapy. And the CBT-informed therapies, focus on different aspects. It's more focused in the here and now and in crisis intervention, symptomatic reduction. The psychodynamic psychotherapy tends to understand what's at the root of the problem. And there is some evidence showing that people who get psychodynamic psychotherapy or more intensive, higher dose psychotherapy may actually do a little bit better if they have severe psychiatric psychopathology. And by that I mean personality disorders and mood or anxiety disorders in combination, perhaps with also chronic medical illness. So the typical patient that we treat, someone who presents with what we used to call in DSM-4 axis 1, axis 2, axis 3, comorbidity, those are the patients that do better with the higher dose psychotherapy. Someone who comes in with social anxiety and your social anxiety, a short course of CBT may be enough. But someone who comes in with narcissistic personality disorder, recurrent major depression, and has a diagnosis of multiple sclerosis with an uncertain prognosis, that patient will do better with a higher dose psychotherapy. And this is a summary of what psychodynamic psychiatry is about. The practice of psychodynamic psychotherapy takes place within a continuum of supportive, expressive, and uncovering interventions, and in multiple settings. So the old classical notion that psychotherapy takes place in an office setting with patients who have a lot of psychological insight, privately, basically people who are professionals who are well off, who are very neurotic and have maladaptive style of behavior, that is just one very small aspect of what psychodynamic psychotherapy do. It's actually a type of psychotherapy that can be applied in every single psychiatric setting, from emergency room to the inpatient setting to the outpatient setting, and the bedside in the general medical hospital. And we'll prove that today. So these are some outdated psychoanalytic concepts and practices. This is what psychoanalysis contributed to psychiatry at the very beginning of the 20th century. And these concepts are proven either not to be so clinically helpful or to be, what we consider now outdated. And, number 2 and 3, I think, are very important. And that is that because of historical reasons, too much emphasis was given at the beginning of the history of psychoanalysis and the history of the development of psychotherapy to sexuality. In particular, infantile sexuality. This is really not so clinically relevant and maybe inaccurate. More emphasis should have been given to aggression and aggressive drives as opposed to sexual drives. But that's how, that was what was necessary at the time, and we are not going to be anachronistic in our criticism. So that has its place in history. It is not how we think or how we formulate at this point. Excessive emphasis on analysis of transference, for example. Transference is a concept that's difficult to understand, that's difficult. There is research now that shows that transference interpretations are only helpful when you have two particular personality disorders, narcissistic personality or borderline personality. If you do not have those personality disorders and you do transference work, transference interpretations, you're really wasting your time and your patient's time. And this has been proven in double-blind control studies where certain experienced psychotherapists were asked to do transference interpretations in high-dose, long-term control settings, and some were told, do not do transference interpretations, and they looked at outcome. So only for patients who have extreme difficulty relating to others, then you use your relationship with the patient as a way to rehearse a better way to relate to others outside of the office setting. And that's basically what a transference analysis is. You know, you use your connection with the patient in the therapeutic setting as a theater stage where you rehearse better ways of connecting to others. Very difficult to do because in order to get the patient to cooperate to do that, you have to work very hard on establishing a therapeutic alliance. And absolute determinism means, you know, it's the classical psychoanalytic joke that a person gets into an elevator and a psychoanalyst is in the elevator and the stranger says, "Good morning." And the psychoanalyst says, "Well, what do you mean by that?" The word determinism should be substituted with meaningfulness. All behavior is meaningful, potentially very meaningful, but sometimes not so meaningful. But not everything needs to be analyzed or dissected or psychologized so much. That's actually an intellectualization defense of ours that we use that sometimes distract us from the human connection and the need to really be there with the patient and connect empathically with their distress. So what is psychiatry's place in medicine? It has oscillated between psychology and neuroscience. And you know, the pendulum, depending on the point in history, the pendulum swings. Psychiatry really started as an offshoot of neurology. Psychoanalysis was invented by a neurologist. So, you know, the pendulum keeps swinging back and forth. Right now we're at a point where a field called, for example, neuropsychoanalysis is gaining a lot of traction in Northern Europe, in South Africa, in Canada. And fantastic work is being done by that. Psychodynamic psychiatry embraces neuroscience, social sciences, and psychological theories, including psychoanalysis and attachment theory. So I think that the more open-minded you are and the more you try to integrate advances in neurosciences, but also psychological theories that are developed via clinical observation, you know, it can all be integrated or it can be considered simultaneously. And a model that is incredibly relevant, and I think will continue to be relevant for as long as medicine exists, is the biopsychosocial paradigm. Medicine needs to be concerned with human experiences, disease abstractions, biochemical abnormalities, genetic determinants, environmental influences, and psychosocial variables that determine disease onset and progression. So basically the biological, the psychological, the social, cultural, religious spheres, they all affect onset of illness, disease progression, and response to treatment. And this applies in all medical specialties, psychiatry included. Whenever I encounter a clinical dilemma when I'm doing psychotherapy supervision and I cannot decode or solve the problem, many times I try to shift paradigms, and I find this very helpful, and I encourage you to try to do this if you are working in supervision or if you have a clinical conundrum, and that is to reframe the problem from the perspective of bioethics. You know, just identify what are the bioethical principles that are relevant. I mean, this is a list of the most comprehensive bioethical principles. And then you see which of these principles are at stake and in conflict in your particular clinical conundrum. And that may be of help in terms of solving an apparently unsolvable situation. The way bioethics committees work is that there is no one has the final answer when there is a complex problem to solve. Bioethical problems are solved by consensus. You know, you get a group of experts, like every person or every other person in this room, to sit together, you present the problem to the experts, and everyone deliberates until you reach consensus. If you don't reach consensus, you cannot give a recommendation to inform clinical practice. It's a very difficult process, especially when we're talking about very complex issues. Psychiatric issues can be, complex psychiatric dilemmas can be looked at from the bioethics lens as well. So I want to make you aware, or perhaps you are, of some pretty old literature that exists supporting the validity and the powerful effect, clinical effect, positive effect of group psychotherapy with medically ill populations. This has been done in different settings with different types of illnesses with pretty extraordinary results. And the reason that I'm making an effort to propose this mode of treatment is that in places where resources are limited, faculty resources, clinical resources are limited, you can really maximize your effort. If you have 25 patients in one room and 90 minutes of work as opposed to seeing 25 patients for 10, 20, 30, 45 minutes each individually. And, and some of this research suggests that the group psychotherapy intervention is actually superior to the individual psychotherapy intervention for these particular disorders. 20% reduction in mortality when compared to treatment as usual in patients with heart disease. Fozzi at UCLA showed that patients with advanced malignant melanoma who had a very short course of CBT, manualized group psychotherapy, lived twice as long. Spiegel showed the same back in the 1980s with patients with stage 4 metastatic breast cancer. So if they were to live 18 months, they got to live 36 months. Quality of life improved because of the benefit of psychotherapy, but also prolonged survival. This was not expected. They were just measuring quality of life, but patients here ended up living longer. The first study was actually the one of Spiegel in California in the late 1980s. Same has been shown with GI malignancies, hematologic cancers, and more recently with HIV. And there is psychotherapy that has been recently developed based on the work of some well-known international psychotherapists, and that is meaning-centered group therapy with persons with advanced illness, manualized recently by Bill Breitbart, who's the chair of psychiatry at Memorial Sloan Kettering in New York Cancer Center, affiliated with Cornell University. But those who are familiar with the work of Viktor Frankl and his writings, see the parallels between one form of therapy and the other. So life has meaning and never ceases to have meaning, even up to the last moment of life. And those of us who have experience working with terminally ill patients are always startled and surprised as to how the person continues to search for meaning, and sometimes even they reverse their own advanced directives. I've encountered so many patients who say, if I ever get to patients who, let's say, have an illness with poor prognosis, and they tell me, if I ever get to this point, please help me die. So they're basically requesting physician-assisted suicide. I don't want to be connected to machines. I don't want to get parenteral nutrition. I don't want antibiotics. I don't want dialysis. As the illness progresses, something happens in the individual. I don't know if it's an instinctual, a life instinct, we don't really understand it. But most patients reverse their original directives and request a little bit more time so they can have an opportunity to establish connections, to take care of unfinished business, interpersonal unfinished business. So searching for meaning may be instinctual and a basic motivation for human behavior. And sources of meaning are multiple. And the beauty of this therapy is that this is manualized, so that when you're doing this type of work and you're not very experienced, you have a handbook in front of you, so that you don't have to figure out what questions to ask, so that you can sort of relax, because it is very anxiogenic to do this type of work, and follow the manual and eventually develop your own style of work. And meaning exists in context. The issue of legacy is of extreme importance, for people to identify, not to try to leave a legacy when they have very little time left. You can't do that at the very end, if you haven't done it so far. But to try to understand what is the legacy that is there that already exists. Typical situation is that people are, that there are unresolved conflicts between family members. And that clouds the person's ability to understand that their children, their grandchildren, the beauty of what they have created as a family unit is probably the most important legacy that anyone can leave. You can write 17 books and lecture all over the world and be a successful politician and have a very important position at a company. But when it comes down to what is most precious, most meaningful, pretty much every person has a substantial legacy that they can recognize and find pride on. So this meaning-centered therapy focuses a lot on that. In order for them to recognize that, you have to help them solve the interpersonal conflicts that exist with family members. It's very difficult because of the anxiety of illness to get to that point unless you do a psychotherapy that will allow them then to identify the legacy and go in peace to the next level of existence. So relationship between stress and illness. Internal psychic demands and environmental interpersonal stressors have an impact on health. I think pretty much everyone in this room will agree on that. But research has examined this question: does stress affect disease onset, progression, course, morbidity, and mortality? The short answer is yes. Does stress affect the integrity of homeostatic and allostatic physiological mechanisms? Absolutely, yes. So let me tell you a little bit about allostatic load. You're familiar with the concept of homeostasis. That's basically the way we achieve balance in a complex system. Allostasis takes that to a third dimension, and that is achieving balance over time. So there is the time factor and the interrelatedness of one system with the other. So erosion of allostasis is what is called allostatic load or allostatic overload. And allostatic overload results from early life stressors, cumulative stressors, or acute stressful life events. What we haven't done until very recently is to look at these possibilities separately. How much of it is early life stressors? How much of what determines a poor disease outcome as opposed to a better disease outcome? Poor adherence as opposed to better adherence? Comorbid psychopathology developing on top of medical illness as opposed to resilience and no psychopathology developing. So we're beginning to separate in research the early life stressors question, cumulative stressors. Is it a quantitative issue? Is it a qualitative issue in terms of the type of stressors that we encounter in life? And we'll review some of that literature a bit later. We know that allostatic overload is associated with immunosuppression, obesity, coronary artery disease, hypertension, increased mortality in general, activation of illness if there is a predisposition. So if you have genetic loading for malignancy, a state of allostatic overload can activate your genetic predisposition, and pretty much all psychiatric disorders as well. Let me tell you about how group psychotherapy began. And this may be, but I remember when I read this for the first time, I could not believe it, and I had to keep searching it because researching it because this was just too odd. Group psychotherapy was started by an internist. It was not started by a psychiatrist. And it was started completely separate from the history of psychoanalysis and psychotherapeutic techniques in Europe. It was somewhere in the northern part of the United States, an internist who was taking care of very ill patients with tuberculosis. There were no effective treatments. It was all, basic psychoeducation for these patients. Try to take care of yourself, rest, go breathe some fresh air, go to the sanatoria where you would basically get a rest cure. This is how tuberculosis was treated in the early 1900s. But the volume of patients sometimes was overwhelming for the busy internist. So Dr. Pratt decided to gather many patients with tuberculosis in a classroom and started instructing them as to how to take care of their health better. So giving them a lesson, an educational lesson on how to care for your health. The patients wanted to hear that, but they also wanted to talk about their emotions. And Pratt was a very astute clinician, internist, a very respectful doctor. So he started just sitting back, relaxing. He was probably exhausted from taking care of so many patients. So he let the patients engage in a group therapy process. So this is how psychotherapy started. Group psychotherapy started. It became very popular with other medical illnesses in internal medicine. And at the beginning, it was called the class method or the class technique, from classroom. It wasn't until 20, 30 years later that psychoanalysts realized that this was going on. So they started moving to the class technique into the setting of psychoanalytic group therapy. And as early as 1927, in Washington, D.C., there was a paper published, presented the group method of analysis in the Washington Psychoanalytic Society in 1925. And I did quite a bit of clinical work at the very beginning of the HIV epidemic in New York City, when treatments were not helpful. When patients, all patients had access to was ACT, one antiretroviral, that was really not so effective. And people at the time used to, the average statistic at the time was like pretty much 2 years from diagnosis to death when you were diagnosed with HIV in the 1980s and 1990s. So for 11 years, I was the clinician in charge of an HIV support group. And these are some of the characteristics of my group. And one of my supervisors in a different institution ran a similar group. And these are some of the characteristics, patient characteristics of the group. As you can see there, my group was an hour and a half. Dr. Cohen's group was an hour long. It really doesn't matter. It's as much time as you have available. The more time, I think, the better. It is very taxing on your psyche as a clinician to sit and conduct a group psychotherapy session for 90 minutes. So, you have to build stamina and resistance. So, and in order to do that, it is helpful to find co-leaders, not to do this by yourself. So I would invite Sister Regina Burns, who was an activist nun working in a Catholic church, taking care of all the AIDS orphans in East Harlem. I would invite members of the social work department in medicine, a rehabilitation counselor to help me with people with addictions. So the more the merrier, the more co-facilitators. Sometimes we had as many co-facilitators of the group as we had patients. And this was very powerful because patients felt that experts were there to listen. But the patients do the work. They do their own psychotherapy. We listen and facilitate the process. And the conceptual work of our group combines elements from Pratt's class technique, in particular the dissemination of medical information. It's a wonderful opportunity to really correct the distortions that patients have about their illness, prognosis, medications. Spiegel's supportive expressive group method. I told you about the work of Spiegel with breast cancer patients, so we incorporated that technique of supportive intervention and encouraging expression of emotion. That's the supportive expressive group method. An interpersonal existential psychotherapy method. This was before the time of Breitbart. So what Breitbart is doing now in terms of meaning-centered used to be called before interpersonal existential psychotherapy. Basically the same notion of trying to find meaning in life at any point in time, especially when you're threatened with the possibility of mortality. In groups or patients with chronic medical illness, as in bereavement groups, the anticipation or experience of the dying process coexists in conflict with an existential yearning for meaning and a sense of time urgency. So this is an important dynamic. So that struggle of trying to find meaning, but then group members have to deal with the reality that maybe 1 week, one group member would not show up because he's or she is either very ill or has died. But this highlighting the conflict in the group or magnifying the conflict in the group really gives the patients an opportunity to master the conflict. So rather than shying away and looking at this and saying, it's like, how can you really master this conflict? It's very difficult to do in an individual treatment. In a group therapy session, it is easier. In the same way that when you have funeral services, the power of the group experience is what really provides consolation to the grieving family. If you visit a person who's grieving one-to-one, you're really not going to have as much of an impact as if you attend funeral services where there's like a ceremonial group activity aspect to it. So converting lost dreams to small hopes becomes a psychotherapy theme. The commonality of experience, concern for each other, and shared support and warmth helps to counteract the losses, rejections, abandonments, and a sense of alienation. These are some of the dynamics that we identified in our work. Interventions are difficult. The major problem is the fine line between encouraging false hopes and providing reassurance. We all struggle with this when we are working with the terminally ill. If you're in a group setting, other patients will help you with this. So if the doctor is sort of overstepping the line and providing false reassurance, the patient actually can correct the doctor's cognitive distortion and help in the process, or the other way around. So the group experience is actually makes this very difficult process easier. Patients are encouraged to reminisce about losses, about the relationships, about the impact of the dying member on their life. Spirituality is emphasized and encouraged. And this happens organically in a group psychotherapy setting. There is no death and dying setting without a spiritual aspect or a religious aspect being an important theme in the process. So regardless of the therapist's sense of comfort with religion or spirituality, the group process attends to that organically. Okay, so we're shifting gears now, and I'm telling you about a very important study that identified remember I told you that there was, that we were beginning to look at research to figure out the importance. Is it early life experiences? Is it a time window of sensitivity or vulnerability that's important in terms of what happens later with health in terms of stressors? Or is it an accumulation of stressors? Or is it the recency of the stressors? So the A study concluded, that was 17,000 patients that were interviewed, concluded that the cumulative effect is more important than the qualitative effect. I mean, I think that's the take-home message of the A study, and that is that the more negative life experiences you have is more important, the quantitative aspect is more important than the qualitative aspect. And we tend to, as clinicians, we tend to be a bit judgmental and assume that, for example, if someone experiences one episode of physical abuse or a few episodes of physical abuse or maybe even sexual abuse, that person will be traumatized for life. And we are surprised when we look at the statistics, for example, in the United States of rape, sexual assault. Yes, 60% of women who are sexually assaulted will develop post-traumatic stress disorder, but 40% do not. And in trying to understand resilience versus development of post-traumatic symptomatology, we're beginning to understand that maybe an important factor is what has happened in addition to that overwhelming life stressor. So an accumulation of stressors is an important factor. When you're doing psychotherapy with young parents, and they tell you that they're arguing, but they're not arguing in front of their children, that they're arguing in the room next door. And I look at them and I say, well, your children are really not that verbal. So when you resurface and reappear from the room next door to attend to your child, they're going to look at your facial expression and the fact that you're going to be still looking enraged and trying to find your composure. So something as minor as family conflict, arguing at home, something as that you may not think that has so much of an impact on children as, for example, if a parent gets intoxicated, the father who comes home after a hard day at work in a very important job and has a couple of drinks, but a couple of drinks actually means that their state of mind changes and the child witnesses that, and they don't understand why daddy looks different when he's intoxicated and when he's not. So we're beginning to look at use of substances at home, parents engaged in criminal activity, parents arguing, in addition to typical emotional, the more classical forms of abuse that we all have been paying attention to as clinicians for the last 150 years, emotional abuse, overt emotional abuse, neglect, physical abuse, and sexual abuse. It is all important. And if you have all of those as opposed to only one of those stressors, that is what creates a state of allostatic overload and will negatively impact not only your psychological health, but your overall systemic health. And this is basically what happens when you experience early trauma and you looked at, and by early trauma I mean the first 3 years of life, or let's say before the child goes to school, when the child is in the home environment the majority of the time. You can see how all psychological disorders increase. Look at the difference between the increased risk of PTSD and increased risk of other psychological disorders. The numbers are not that different, so we think of a connection, automatically we think of a connection between trauma and post-traumatic stress disorder, obviously, but trauma is a precondition for many other psychiatric disorders. Increased risk of harmful use of illicit drugs is almost at the same rate as PTSD. So if you have a patient with addiction, you have to explore early childhood trauma in the same way that if you're treating a patient with PTSD. Okay, so how does this come about? These are like different areas. How do we get from point A to point B? I mean, so we know the clinical findings, the surveys, patients have been interviewed, followed up over time, and now we're beginning to try to understand what are the mechanisms, the actual biological mechanisms. And some people are looking at inflammatory markers. There's a lot of important findings. That's not the topic of this lecture. And we've known about the body's response to stress mediated by the HPA axis for quite some time, and that can be measured. But what we're beginning to look at now is what is happening at the level of the DNA, and in terms not only of changes in the DNA, but changes in the periphery of the DNA, what we call DNA methylation, which is the most widely studied epigenetic mechanism, and I will review what that means to you now. So epigenetics is the alteration of gene activity without changes in DNA sequences. And how does this happen? Epigenetics, according to Joanna Chambers, who is the current president of the American Academy of Psychodynamic Psychiatry and Psychoanalysis, is the underlying mechanism for all of neuroscience and behavior. That's quite a categorical statement. So you cannot look at neuroscience unless you understand epigenetics. Epigenetic processes occur mainly through DNA methylation and acetylation. We are focusing more on DNA methylation at this point. This is all very recent, so we may find also surprising findings in other mechanisms of epigenetic changes. And DNA methylation is triggered by toxins, pollutants, bacteria, viruses, radiation exposure, nutritional changes. It can all alter, our constitution at the very core. Hormonal exposure, changes in the utero, but also environmental stressors. So what happens outside of the body can have similar impact at the level of our DNA as what happens internally. Remember Freud's theory of the id, the ego, and the superego, and the intrapsychic processes. When he devised that theory, it gave psychoanalysts the opportunity to focus on the ego, and the field of ego psychology took the intrapsychic processes outside. The ego is the part of the mind that relates not only to your internal demands, how your morality, your sense of what's right or wrong is in conflict with your sexual and aggressive drives. That is the intrapsychic paradigm, but the ego has to negotiate that conflict between id and superego, but also between the internal demands and the external demands, the external stressors. So that's why the ego is like the chief operating officer of the mind. It has a very difficult job of juggling what happens internally, externally, and the way we adapt to the environment is called defense mechanisms. So you see how we're now looking at a psychological theory. You can actually say that's a particular psychological theory that was developed based on clinical observation can be validated at the level of genomics. So DNA methylation occurs with the addition of methyl groups to cytosines in the DNA sequence. It can alter gene expression, providing a mechanism by which gene and environment interactions affect biological responses. Now, again, three areas of research that are developing. Is there a sensitive period for epigenetic programming? If DNA methylation happens at a particular time in life, is this correlated with development of illness more so than in other times of life? We're looking at the accumulation model. If stressors occur over time and accumulate, what impact does that have at the level of the DNA? And the recency model, something happens to you that's very tragic very recently, how does that affect disease onset, disease progression, your overall health? Clinically, I think we would all assume that all of it is important, right? When you do a history of present illness, you look at the recency model, that's basically your HPI. The accumulation model is your past history, and sensitive period is if you have a psychodynamic understanding and you know that early experiences affect your current behavior, you look at past experiences. So we've been doing this all along, but what we haven't done is to figure out what is most important and what comes first and what type of impact does this have. The effect of adversity on DNA methylation depends primarily on the developmental timing of exposure. This may come as a surprise to you. Exposure in a very early childhood was associated with DNA methylation differences for nearly all adversity types. In contrast, the effects of exposure in middle childhood were largely detected only for the most severe forms of adversity exposure. So again, the qualitative and the quantitative, but also the sensitive period. What happens early in life, regardless of how bad or not so bad is the most terrible. What happens later in life, if it's really bad, it will affect your overall health and your psychological health. So in this study that was a meta-analysis that was published 2 months ago exactly, when adversity occurs early in life, it coincides with the initial and foundational sculpting of brain architecture. And early in life, in these epigenetic studies, means the first 3 years of life. So why is this important to us? Well, because psychotherapy may be able to recalibrate sensitivity to the social context and the environment, and as the environment produces biological changes that result in epigenetic modifications, psychosocial interventions can have a similar effect. So a hypothesis has been, if you follow our clinical intuition and accumulated experience, that perhaps psychotherapy can offer an opportunity for demethylation. So you have DNA methylation caused by environmental stressors, in the same way that attachment theorists talk about an opportunity for earned attachments. People who do not have the beauty of a stable early home environment, they can make up for that with reparative life experiences. They find themselves a good relationship, a good group of friends, a good psychotherapist. So their early chaos can be modified, and you can go on to live your life in a healthier way. Well, here you have a correlate where we're now understanding that psychotherapy not only gives you an opportunity for earned attachments if you use psychological language, but it is involved in a process of demethylation when DNA methylation occurs. And there was a systematic review done by a collaboration between a university in Santiago de Chile and the UCL in the UK by some really prominent researchers. And I encourage you to look at these studies. And I am summarizing the findings of very recent studies measuring DNA methylation and measuring psychotherapy as a way to reverse the process with different types of patient populations, different types of psychotherapy interventions, most of these short-term manualized treatments. So you don't need to be in psychotherapy for a long time to sort of get your DNA washed up. It's like taking your car to the car wash. It's not about, really having to get a new car. I mean, that's a very crude analogy. So in the first study, intensive DBT was offered for 4 weeks. DNA extraction was performed on blood leukocytes before and after psychotherapeutic intervention, and the percentage of methylation in a particular gene that we know has been associated with psychopathology and distress in borderline personality disorder we saw that the before and after measurements of methylation, demethylation as a result of psychotherapy were there. The same, and you know, this is this particular study, which is the one that sort of set the stage for other studies with other patients. So there was another study of patients with agoraphobia where they not only had symptomatic reduction, but demethylation occurred after 6 weeks of CBT. You know, very short intervention. Rachel Yehuda, if you're interested in PTSD and PTSD research, you must read her work. You know, she's really, in my opinion, the top person in the world looking at PTSD. And she found that PTSD responders and her team, PTSD responders to prolonged exposure therapy showed decrease in DNA methylation. So we're beginning to see this in all sorts of psychiatric disorders with different interventions. And other groups provided 12 weeks of CBT for anxiety disorders in children. You know, here we're studying a population of children. Decreased methylation levels in a particular gene that correlates with, that we know from our advances in genomics, correlates with anxiety. 6 weeks of CBT and medication for major depressive disorder. This is a study looking at both the impact of, you know, what we usually do. We provide medication and we provide psychotherapy. So they were just curious to see if the changes occur when you do combination treatment, and they do. The methylation of a particular gene that's associated with depression occurs. So rather than concluding here, what I would like to do is raise some questions. Does DNA methylation of peripheral tissue sample, blood cells, which is what we usually measure, adequately correlate with DNA methylation changes in the brain? There is enough literature showing that it does, but I am not an expert in genomics, so I would like to learn a little bit more. You know, I would like to be convinced that this is the case before we go on around the world with these categorical assumptions saying, you know, we're changing, psychotherapy is changing people's DNA. It's like, let's just make sure that this is happening in the brain. We have a lot of experiences with systemic treatments that may or may not cross the blood-brain barrier, and you know, and for example, I mean, I have a lot of experience working, as I told you, with HIV patients and people with HIV dementia. With some treatments, you know, when they get antiretroviral treatment, their dementia actually improves, but depending on the drug's ability to cross the blood-brain barrier. So what happens in the brain, what happens peripherally, is not always the same. The psychotherapy effect go beyond DNA demethylation, involving other epigenetic processes such as acetylation. I think it would be too simplistic to say this is the answer, this is like the, you know, we have found the genetic connection here to the work that we do. I think we need to look at other mechanisms. We need to study complex relationships between gene environment, and gene culture interactions as well. These studies need to be replicated in other settings, in other countries, with other patients, to see if the findings are different. And we need to study DNA methylation changes in the high-dose psychotherapies. It would be curious to see what happens to these DNA methylation changes over time. Do patients revert back to their previous state? What clinicians are suggesting is that they do not. You know, in the same way that you can earn attachment with a good marriage and repair your chaotic early life experience. But again, this may be a clinical assumption. You know, I think we really need to look at what happens not only what happens over time, but if the high-dose psychotherapies, the long-term psychotherapies, actually have a more robust effect or not. I think we need to be humble enough to admit defeat. You know, here we've been proposing the high-dose long-term psychotherapies as more helpful for people with complex disorders who experience lots of trauma. We need to research this at that level as well. How are we doing in terms of time? How much time do I have left? 5 more minutes? Okay. Let me see where I am in terms of my slides. Okay, I want to tell you about a little bit about the. Thank you. Thank you for staying for most of the lecture. I want to tell you about what we know between the connection between attachment theory and adherence to medical treatment. The determinants of a secure attachment, the determinants of a secure relationship include anticipating the needs of the infant, being sensitive to the needs, being available, and being responsive. And most of this is easy to do. The part that's a little bit difficult, that requires effort and attention, is anticipating the needs. You know, it's like playing chess. You have to be a step ahead, or sometimes 12 steps ahead, when you're doing good enough parenting or good enough relating to others. So in order to create and absolutely cement security during the most vulnerable period of development, you need to do all of this. And what usually results when this is well done is a secure attachment, and 60 to 70% of the population relate securely to one another and feel secure about themselves. But 20% of the general population, they're avoidant of relationships, and they are excessively self-reliant and push important people in their lives away from them because they're not so comfortable with that, because it did not happen in their own experiences during infancy. And there is the other extreme, when people become overtly preoccupied and anxious about relationships and have that type of insecurity. We tend to these are not categorical relationship styles, these are dimensional. So most of us in this room, I would venture to say, are primarily secure and secondarily avoidant. Would that sound familiar? Maybe a minority here are primarily secure and secondarily anxious. Okay, I think that would be, if I were to do a relationship questionnaire on everyone in this room, I can guarantee that most people are going to be secure, but some of you are going to be secondarily avoidant, and then a lesser number of you are going to be secondarily anxious. I doubt that anyone here has disorganized attachment. You wouldn't be able to get to this point in life. That happens to 5% of the population or less, and that correlates with severe personality disorders and psychotic states. What's important here is that the only attachment style that strongly correlates with treatment adherence is secure attachment, and with treatment non-adherence is avoidant attachment. So if you're working in the CLP setting, you better be able to identify your patient's attachment style, so then you can predict adherence to medical treatment. You're working with a diabetic patient, you're working with a patient that requires, an oncology patient that requires to really follow the doctor's protocol, because if not, their health will not progress. You identify their attachment style, then you can focus on building a therapeutic alliance. What we know is that, and this is the research that correlates that. It was studied in large cohorts of diabetic patients in primary care. And what's most important here is that the avoidant individuals, and this is counterintuitive, they respond better to psychodynamic psychotherapy. You can take the word psychodynamic here and put high-dose psychotherapy, intensive psychotherapy. Avoidant individuals respond better to intensive psychotherapy than those with anxious attachment. So I would have expected the opposite. The anxious patient comes to you and they do okay in psychotherapy, they become less anxious. But in terms of changing their character style, you have a better chance at making an avoidant person secure than you have a chance of making an anxious person secure with high-dose psychotherapy. The counterintuitive part here is that the avoidant patients avoid psychotherapy. So the focus should be establishing a therapeutic alliance. That comes first. Once you have a therapeutic alliance, and the patient continues to engage in the treatment in a regular basis, then you'll see good results. I think I'll skip the part about countertransference just for the sake of time management. The liaison psychiatrist is a mediator, coordinator, educator, negotiator, link, and conduit. Sounds like a lot of jobs for one person, right? Feeling isolated, helpless, and frustrated may lead to deterioration of communication, diplomacy, and decorum. So many times when we're working with patients who have complex illnesses, in toxic environments where there's a lot of aggravation and a lot of tension, people actually turn against the other, and it's no different than trying to find order in a political group, or in a board meeting. People tend to regress when they're stressed, and that includes our colleagues in internal medicine and in surgery. That includes ourselves, and our job as a CLP psychiatrist really is to become a role model, to maintain our composure at all times, and to let others borrow on our ego strength. And that includes not only the patients, but the medical practitioners. We're not there to engage in infantile exchanges and regress fights with the system. It is very tempting to do that because we ourselves are stressed by the system as well. But your job, in the same way that a child, when a child regresses, a parent maintains her composure and his composure, and if you don't, you're not going to stop the tantrum. Same principle applies in the CLP setting. Okay, so in conclusion, dynamic factors are inherent in interactions between doctors and patients. Interpersonal tension contributes to conflict and may negatively impact clinical care. Examining countertransference in the general hospital could be useful in understanding elusive dynamics between patients and providers. And awareness of countertransference is necessary in the CLP setting. Attachment theory informs psychodynamic and CLP psychiatry. This avoidant attachment and secure attachments correlate with non-adherence and adherence, respectively. Avoidant attachment is the one that responds the best to the higher dose psychotherapies. There is robust evidence that providing that psychotherapy interventions improve quality of life, decrease morbidity, and prolong survival. Every brief clinical encounter can be therapeutic when awareness of underlying psychodynamics informs practice. Psychotherapy as a biological treatment is now proven to reverse toxic DNA methylation processes caused by early life adverse events and recent stressors. And you have many references here for everything that I have said, including the very recent studies recent publications as of 2 months ago. If you have difficulty finding any of these articles, write to me, and I will not send them in this transportation. I'll send them to you via email. I think this is one of the most beautiful vehicles in the world. And here's my email address. Thank you so much for your attention. Please write to me with questions, and if you wish to have a copy of the presentation as well.
Thank you, Professor Cesar Alfonso. Distinguished guests, ladies and gentlemen, this is the end of the conferment ceremony of Adjunct Professor. We welcome you to congratulate Professor Cesar Alfonso MD and take a group photo in front of the stage. We would like to say thank you to all guests, and we apologize for any inconvenience. Good morning.